HY, Review, Biostatistics Essentials. 40 questions on the numbers you must be able to run in your head on test day. Test characteristics and measures of association. Read the command, do the math, commit and move. Clock starts now. What is the sensitivity of the rapid test? A new rapid test for active tuberculosis is checked against sputum culture. Of 100 patients with culture, proven TB, 95 test positive. Of 400 patients without TB, 360 test negative. Read the command. Sensitivity. Sensitivity is true positives over everyone who truly has the disease. Sensitivity is the fraction of people with the disease that the test correctly calls positive. True positives divided by all who have the disease. Here, 95 of the 100 culture-proven TB patients test positive, so sensitivity is 95 over 100, or 95%. Sensitivity looks only at the disease column. The correct answer is B. The value 90% is the specificity, 360 of 400 healthy people testing negative, which uses the other column, not sensitivity choice, A wrong. The 5% is the false negative rate, the 5 diseased patients the test missed. That is the complement of sensitivity, not sensitivity itself, choice, D wrong. True positives over all disease gives a sensitivity of 95%. What is the specificity of the rapid test? Using the same tuberculosis study of 100 patients with TB, 95 test positive, of 400 patients without TB, 360 test negative, and 40 test positive. Read the command. Specificity. Specificity is true, negatives over everyone who is truly healthy. Specificity is the fraction of healthy people the test correctly calls negative, true negatives divided by all without the disease. Here, 360 of the 400 people without TB test negative, so specificity is 360 over 400, or 90%. Specificity looks only at the non-disease column. The correct answer is D. The value 95% is the sensitivity, which comes from the disease column, not the healthy one. Choice A wrong. The 10% is the false positive rate, the 40 healthy people who tested positive, which is the complement of specificity, not specificity itself. Choice E wrong. True negatives over all healthy gives a specificity of 90%. What is the positive predictive value? A screening test is applied to 200 people. Of the 50 who truly have the disease, 45 test positive. Of the 150 who are disease-free, 15 test positive and 105 test negative. Read the command, positive predictive value. Of everyone who tests positive, how many truly have the disease? Positive. Predictive value answers a different question than sensitivity. Of all the people who test positive, what fraction truly have the disease? That is true, positives divided by all positives. Here, 45 true positives plus 15 false positives make 60 positive tests, and 45 of them are real, so PPV is 45 over 60, or 75%. The correct answer is A. The value 90% is the sensitivity 45 of 50 diseased, or specificity 135 of 150 healthy, which read down the disease columns, not across the positive test row. Choice B wrong. The 96% is the negative predictive value, the mirror measure for negative tests. Choice C wrong. True positives over all positives gives a PPV of 75%. What is the negative predictive value? Using the same screening study, 50 people had the disease, 45 test positive, 5 negative, 150 are disease-free, 135 test negative, 15 positive. Read the command, negative predictive value. Of everyone who tests negative, how many are truly disease-free? Negative predictive value is the fraction of people who test negative who are truly disease-free, true negatives divided by all negatives. Here, 35 true negatives plus 5 false negatives make 140 negative tests, and 135 are truly healthy, so MPV is 135 over 140, about 96%. It reads across the negative test row. The correct answer is E. The value 75% is the positive predictive value, the mirror measure for positive tests, not negative ones, choice A wrong. The 90% is a sensitivity specificity figure read down the disease columns rather than across the negative test row, choice B wrong. True negatives over all negatives gives an MPV of about 96%. What happens to the positive predictive value in the general public? A test with a fixed sensitivity of 90% and specificity of 90% is first used to screen a high-risk clinic where disease prevalence is 30%, then used to screen the general public where prevalence is only 1%. Read the command PPV when prevalence drops to 1%. Rare disease means most positives are false alarms. PPV depends heavily on prevalence. When disease is rare, even a good test produces mostly false positives, because the huge healthy group generates many positives while the tiny disease group generates few. At 1% prevalence, a 90-90 test has a PPV of only about 8%, so PPV falls markedly compared with a 30% prevalence clinic. Sensitivity and specificity being test properties do not change. The correct answer is C. Saying PPV is unchanged confuses it with sensitivity and specificity, which are the prevalence-independent properties. PPV always moves with prevalence. Choice B wrong. Sensitivity does not fall with prevalence. It is fixed by how the test performs in the diseased, regardless of how common the disease is. Choice D wrong. Lower prevalence makes PPV fall markedly. What does a negative result on a highly sensitive test allow? A clinician uses a highly sensitive D-dimer test in a low-risk patient to help decide about pulmonary embolism. The result comes back negative. Read the command. What a negative, highly sensitive test does. A sensitive test that is negative rules the disease out. A highly sensitive test catches almost everyone with the disease, so it produces very few false negatives. That means a negative result is trustworthy for ruling out disease. The memory hook is SN-NOUT, a sensitive test that is negative rules OU. A sensitive test is best for screening, where you cannot afford to miss cases. The correct answer is B. A positive result on a sensitive test does not confirm disease, because a sensitive test still has many false positives. Confirmation is the job of a specific test, choice A wrong. A negative result cannot confirm disease. That pairing is backwards, choice D wrong. A sensitive test that is negative rules the disease out. What does a positive result on a highly specific test allow? After a positive screening test, a clinician orders a highly specific confirmatory test, which also comes back positive. Read the command what a positive, highly specific test does. A specific test that is positive rules the disease in. A highly specific test rarely calls a healthy person positive, so it produces very few falsely positives. That means a positive result is trustworthy for ruling in disease. The hook is CPN, a specific test that is positive rules IN. Specific tests are used to confirm a diagnosis after a sensitive test screens. The correct answer is D. Because a specific test has few false positives, a positive result is not likely to be a false alarm, the opposite of ruling in choice E wrong. A positive result rules the disease IN, not out. That pairing is reversed. Choice B wrong. A specific test that is positive rules the disease in. What is this strategy called, and what does it do? To confirm a diagnosis, a clinician performs a second test only on patients who were positive on the first and diagnoses disease only when both tests are positive. Read the command, name the strategy and its effect. Requiring both tests positive is sequential and tightens specificity. Running tests one after another and requiring both to be positive is serial sequential testing. Demanding two positives makes a positive call harder to reach, So it raises specificity and positive predictive value, good for confirming disease, at the cost of some sensitivity. This contrasts with parallel testing order both at once, positive if either is positive, which raises sensitivity for screening. The correct answer is A. Serial testing raises specificity, not sensitivity. Requiring two positives makes false positives rare, which is the opposite of a sensitivity gain. Choice C wrong. Parallel testing, where either positive counts, is the strategy that raises sensitivity, and it is not what is described here. Choice B wrong. Requiring both sequential tests positive is serial testing that raises specificity. What is the positive likelihood ratio? Ratio LR plus. A diagnostic test has a sensitivity of 90% and a specificity of 80%. Read the command, the positive likelihood ratio. Use sensitivity over 1 minus specificity. The positive likelihood ratio is sensitivity divided by 1 minus specificity. How much more likely a positive result is in a disease than a healthy person. Here that is 0.9 divided by 1.0.0.0.0.0. 20.5 meaningfully raises the probability of disease after a positive test. The correct answer is E. The value 0.125 is the negative likelihood ratio. One sum is SP, which applies to a negative result, not a positive one. Choice B wrong. The 0.9 is simply the sensitivity, not a likelihood ratio. Choice A wrong. Sensitivity over 1 minus specificity gives an LR plus of 4.5. What is the negative likelihood ratio? Light. The same test has a sensitivity of 90% and a specificity of 80%. Read the command, the negative likelihood ratio. Use 1 minus sensitivity over specificity. The negative likelihood ratio is 1 minus sensitivity divided by specificity. How much a negative result changes the odds of disease? Here that is 1 needle 90 divided by 180 needle 9 needle 180 needle 9 needle. Well below 1 means a negative test substantially lowers the probability of disease. The correct answer is C. The value of 4.5 is the positive likelihood ratio, which applies to a positive result, not a negative one. Choice A wrong. The 0.2 is just one molecule specificity, one piece of the formula, not the completed negative LR. Choice B wrong. 1 minus sensitivity over specificity gives an LR 125. What is the approximate post-test probability? A patient has a pre-test probability of disease of 50%. A test with a positive likelihood ratio of 9 comes back positive. Read the command, post-test probability after a positive LR9 test. Convert to odds, multiply, convert back. Likelihood ratios act on ODDS. A pretest probability of 50% is odds of 1 to 1, or just 1. Multiplying by the positive LR of 9 gives post-test odds of 9. Converting odds of 9 back to a probability, 9 divided by 9 plus 1 gives about 90%. So a strong positive test pushes this patient from a coin flip up to roughly 90%. The correct answer is A. A positive test is informative, so the probability does not stay at the pretest 50%. Choice B wrong. About 9% comes from misusing the LR as if it were a probability rather than a multiplier of odds. The true value moves UP, not down to 9%. Choice C wrong. Odds of 1 times 9 gives a post-test probability of about 90%. How should they set the test cutoff? A public health team is designing a screening test for a serious but treatable disease. They want to miss as few true cases as possible and accept that a later confirmatory test will sort out the false positives. Read the command, how to set a screening cutoff. Screening must not miss cases, so favor sensitivity. A screening test is meant to catch as many true cases as possible, so its cutoff should maximize sensitivity, accepting more false positives that a later confirmatory test will weed out. Missing real cases is the costly error in screening, so you lean toward high sensitivity even at the expense of specificity. The correct answer is E. Maximizing specificity is the goal of a confirmatory test, not a screening test, because confirmation aims to avoid false positives rather than missed cases choice, a wrong. Setting the cutoff at the far right of the ROC curve pushes toward high specificity and low sensitivity, the opposite of what screening needs choice be wrong. A screening cutoff should maximize sensitivity. Which factor must support screening for that disease? A committee is deciding whether a particular disease is suitable for a population-wide screening program. Read the command, what makes a disease worth screening? There must be an early stage you can find and treat. Screening only helps when a disease has a detectable preclinical stage and an effective early treatment, so that finding it sooner actually changes the outcome. A Core Wilson. Jungner criterion. A disease with a treatable early phase is exactly the kind worth screening. Catching it early lets you intervene before it becomes symptomatic or incurable. The correct answer is B. If there is no available treatment, detecting the disease early cannot improve the outcome, which undermines the whole point of screening. Choice C wrong. A very rare disease is a poor screening target because low prevalence drives the positive predictive value down and floods the program with false positives. Choice A wrong. A detectable, treatable early stage is what most support screening. What is the one-year incidence, cumulative incidence? In a town of 10,000 people who are all disease-free at the start of the year, 200 new cases of a disease developed during that year. Read the command, cumulative incidence, new cases divided by the population at risk over the period. Cumulative incidence is the number of new cases divided by the population AT risk at the start over a set time. Here, 200 new cases arise among 10,000 at-risk people in 1 year. 200 divided by 10,000 is 2.02, or 20 per 1,000 per year. Incidence counts only new cases in the previously disease-free group. The correct answer is D. The value 2 per 1,000 is off by a factor of 10, a decimal slip in dividing 200 by 10,000 choice, a wrong. The 200 per 1,000 wrongly treats the 200 cases as if the denominator were 1,000 rather than 10,000. Choice B wrong. 200 new cases among 10,000 at risk is an incidence of 20 per 1,000 per year. What is the incidence rate? A cohort study follows its participants for a combined total of 500 person years, during which 25 new cases of the disease occur. Read the command, incidence rate, new cases divided by total person time. An incidence rate uses person time in the denominator, which accounts for people being followed for different lengths of time. Here, 25 new cases occur over 500 person years. 25 divided by 500 is 0.9, or 5 cases per 100 person years. Person time density is the right denominator when follow-up varies. The correct answer is C. Framing it as 25 per 500 people treats the denominator as persons rather than time, losing the time dimension that defines a rate. Choice A wrong. Calling it a 5% lifetime risk mislabels an incidence rate as a cumulative lifetime probability, which is a different quantity. Choice B wrong. What is the point prevalence of influenza on April 1? A survey of 300 nursing home residents is done on a single day, April 1, and finds that 30 currently have influenza. Over the entire month of April, a total of 60 residents had influenza at some point. Read the command, point prevalence on one day, existing cases on that day over the population. Points. Prevalence is the proportion of a population that has the disease at one moment in time. On April 1, 30 of the 300 residents currently have influenza, so point prevalence is 30 over 300, or 10%, It counts everyone with disease on that single day, regardless of when they got it. The correct answer is A. The 20% is the period prevalence for the whole month. 60 of 300 residents ill at some time in April, not the single day snapshot. The question asks for choice B wrong. The 30% simply misreads the count 30 as a percentage instead of dividing by the 300 residents. Choice C wrong. Cases present on April 1 over the population gives a point. Prevalence of 10%. What happens to the prevalence? A chronic disease has a steady incidence. A new therapy roughly doubles how long patients live with the disease without curing them, while the number of new cases each year stays the same. Read the command, effect on prevalence. Prevalence tracks incidence times duration. Prevalence is approximately incidence times duration. If a therapy doubles the duration patients live with the disease while incidence is unchanged, prevalence roughly doubles as patients accumulate. Prolonging life without curing swells the pool of people living with the disease. The correct answer is E. Saying prevalence is unchanged ignores that a longer duration lets cases pile up, which is exactly what raises prevalence. Choice B wrong. Incidence is stated to be constant, so it does not double. Only duration changed. Choice C wrong. Doubling duration with steady incidence roughly doubles prevalence. What is the attack rate among guests who ate the potato salad? At a wedding reception, 200 guests ate the potato salad, and 50 of them developed gastroenteritis over the next day. Read the command, attack rate in the exposed, ill people divided by those exposed. An attack rate is a cumulative incidence used in outbreaks, the number who become ill divided by the number E exposed over the outbreak period. Here, 50 of the 200 guests who ate the potato salad got sick, so the attack rate is 50 over 200 or 25%. It measures how infectious a given exposure was. The correct answer is B. The 50% mistakes the case count of 50 for a percentage instead of dividing by the 200 exposed guests. Choice A wrong. The 75% is the proportion who stayed WE well, the complement of the attack rate, not the attack rate itself. Choice E wrong. 50 ill among 200 exposed is an attack rate of 25%. What is the case fatality rate? During an outbreak of a severe infection, 400 people develop the disease and 40 of them die of it. Read the command, case fatality rate, deaths from the disease divided by those who have it. The CAC fatality rate is the proportion of people with a disease who die of it, deaths divided by cases. Here, 40 of the 400 people who developed the infection died, so the case fatality rate is 40 over 400, or 10%. It measures how deadly the disease is once you have it, not how common it is. The correct answer is D. The 40% mistakes the death count of 40 for a percentage rather than dividing by the 400 cases. Choice A wrong. The 90% is the proportion who survived, the complement of case fatality, not the fatality itself. Choice E wrong. 40 deaths among 400 cases is a case fatality rate of 10%. What is the odds ratio? In a case control study, among 100 patients with the disease, 80 had the exposure. Among 100 controls, 50 had the exposure. Read the command, odds ratio, cross. Multiply the 2 by 2 table. The ODDS RATO cross multiplies the 2 by 2 table. Exposed cases times unexposed controls over unexposed cases times exposed controls. Here, that is 80 times 50 over 20 times 50, 4,000 over 1,000, which equals 4 times the odds of exposure compared with controls. The correct answer is C. The value 1.6 comes from naively dividing the exposure counts 80 over 50 as if computing a risk ratio, but case control data require the cross product, not a simple ratio. Choice A wrong. The 8.0 doubles the correct value through an arithmetic slip in the cross multiplication. Choice D wrong. The cross product gives an odds ratio of 4.0. What is the relative risk? In a cohort study, the disease develops in 40 of 200 exposed people and in 10 of 200 unexposed people. Read the command, relative risk, risk in the exposed divided by risk in the unexposed. A relative risk is the risk in the exposed divided by the risk in the unexposed. The exposed risk is 40 of 200 or doing 20. The unexposed risk is 10 of 200 or doing 05. Dividing gives doing 20 over doing 05, which is 4. The exposed have 4 times the risk. Cohorts measure incidence directly, so true risk ratios are valid. The correct answer is E. The value 0.25 is the ratio inverted unexposed over exposed, which would suggest a protective effect and is the wrong direction. Choice A wrong. The 30 is the excess count 4510, an attributable risk idea, not the ratio. Choice C wrong. Exposed risk over unexposed risk gives a relative risk of 4. What is the absolute risk reduction? In a randomized trial, the primary event occurs in 20% of the placebo group and 5% of the treatment group. Read the command, absolute risk reduction, subtract the treated event rate from the control event rate. Absolute risk reduction is simply the control event rate minus the treatment event rate. Here 20% in placebo minus 5% in treatment equals 15 percentage points. It tells you in absolute terms how much the treatment cut the event rate, the raw difference, not a ratio. The correct answer is A. The 75% is the relative risk reduction, the 15-point drop expressed as a fraction of the 20% baseline, not the absolute difference. Choice D wrong. The 5% is just the treatment group's event rate, not the reduction from placebo. Choice E wrong. Subtracting the rates gives an absolute risk reduction of 15%. What is the relative risk reduction? The same trial shows an event rate of 20% with placebo and 5% with treatment. Read the command. Relative risk reduction. The absolute reduction as a fraction of the control rate. Relative risk reduction expresses the absolute reduction as a fraction of the control rate, control minus treatment, divided by control. Here that is 15% divided by 20%, which equals 75%. The treatment cut the event rate by 3/4 relative to placebo, a figure that sounds larger than the 15-point absolute drop. The correct answer is C. The 15% is the absolute risk reduction, the raw difference, not the reduction relative to baseline. Choice A wrong. The 25% is the treatment rate as a fraction of the control rate, 520, which is the residual risk ratio, not the reduction. Choice B wrong. Dividing the 15-point drop by the 20% baseline gives a relative risk reduction of 75%. Approximately how many patients must be treated to prevent one event, net NNT? The same trial has a placebo event rate of 20% and a treatment event rate of 5%. Read the command, number needed to treat. Take the reciprocal of the absolute risk reduction. Number needed to treat is 1 divided by the absolute risk reduction. The AR here is 15% or 0.15, so NNT equals 1 over 0.15, which is about 6.7. Round up to 7. You must treat roughly 7 patients to prevent one event. The correct answer is B. The value of 15 confuses the ARR percentage with the NNT. The NNT is the reciprocal of the ARR, not the ARR itself. Choice A wrong. About 1.3 comes from taking 1 over the relative risk reduction 1.75 instead of the absolute reduction. Choice E wrong. 1 over 0.15 again gives an NNT of about 7. What is the number needed to harm? A drug causes a particular adverse effect in 12% of treated patients compared with 2% of untreated patients. Read the command. Number needed to harm. Reciprocal of the excess harm rate. number needed to harm is 1 divided by the attributable risk of harm, the extra harm the drug causes. The excess is 12% minus 2%, which is 10%, or 0.U10. NNH equals 1 over 0.U10, which is 10. On average, treating 10 patients produces 1 extra adverse event. The correct answer is D. The value 12 uses the treated group's raw harm rate instead of the excess above baseline choice, A wrong. The 100 comes from taking 1 over a 1% difference, but the true difference is 10%, not 1% choice, C wrong. 1 over the 10% excess gives an NNH of 10. What is the attributable risk in the exposed? The incidence of a disease is 8 per 100 among exposed people and 3 per 100 among unexposed people. Read the command. Attributable risk in the exposed. Subtract the unexposed risk from the exposed risk. Attributable risk in the exposed is the EXCSS risk exposure adds the exposed risk minus the unexposed risk. Here, 8 per 100 minus 3 per 100 equals 5 per 100. The extra cases per 100 exposed people that can be blamed on the exposure. It is a difference, measured in the same units as the risk. The correct answer is E. The 2.7 is the relative risk 8 divided by 3, a ratio rather than the excess difference choice, A wrong. The 62.5% is the attributable risk percent, the excess as a fraction of the exposed risk, 588, not the absolute attributable risk choice, D wrong. Subtracting the two risks gives an attributable risk of 5 per 100. What is the attributable risk percent in the exposed, the fraction of their risk due to the exposure? Using the same figures, disease incidence is 8 per 100 in the exposed and 3 per 100 in the unexposed. Read the command. Attributable risk percent, the excess divided by the exposed risk. A triglyceride percent is the excess risk expressed as a proportion of the exposed group's total risk, exposed minus unexposed divided by exposed. Here that is 8 per 3 divided by 8, or 5 over 8, which is 62.5%. It means about 62.5% of the disease in exposed people is due to the exposure itself. The correct answer is A. The 5% is the absolute attributable risk, 5 per 100, not the percentage of the exposed risk it represents, choice B wrong. The 37.5% is the mirror fraction, 3 over 8, the part of the exposed risk, not due to the exposure choice, C wrong. The excess over the exposed risk gives an attributable risk percent of 62.5%. What is the population attributable risk? In an entire population, the incidence of a disease is 10 per 1,000. Among the unexposed subgroup, the incidence is 4 per 1,000. Read the command, population attributable risk. The whole population risk minus the unexposed risk. Population. Attributable risk is the excess disease in the whole population that is due to the exposure, the total population risk minus the unexposed background risk. Here, 10 per 1,000 minus 4 per 1,000 equals 6 per 1,000. How much the overall rate would fall if the exposure were removed? The correct answer is C. The 60% is the population attributable risk. Percent, the excess as a fraction of the total risk, 6/110, not the absolute PA. The question asks for choice, D wrong. The 2.5 is simply the rate ratio, 10 divided by 4. A ratio rather than a difference, choice, a wrong. The total population risk minus the unexposed risk gives a power of 6 per 1,000. How does the odds ratio relate to the relative risk here? A case-control study of a rare disease population prevalence under 1% reports an odds ratio of 5. A student worries the odds ratio badly overstates the true relative risk. Read the command, or versus RR in a rare disease. When disease is rare, they nearly coincide. Under the rare disease assumption, when a disease is uncommon, the ODDS RITO closely approximates the relative risk. Because few people have the disease, the odds and the risk are numerically similar, so the case control ORA 5 is a good stand-in for the true relative risk. The student's worry is unfounded. The correct answer is B. Relative risk cannot be computed directly from a case control study because subjects are selected by disease status rather than followed for incidence. That is exactly why the OR is used as a proxy. Choice D wrong. The OR does not overstate the RR by a fixed twofold factor. The size of any gap depends on how common the disease is, and here it is negligible. Choice A wrong. For a rare disease, the OR approximates the RR. How should this relative risk be interpreted? A cohort study reports a relative risk of 0.4 for cardiovascular events in patients taking a statin compared with placebo. Read the command. Interpret an RR of 0.4. Below 1 means lower risk. 1 minus the RR gives the reduction. A relative risk below 1 signals a protective effect. An RR of 0.4 means statin patients have only 40% of the event risk of placebo patients, equivalently a 60% lower risk 1 minus 0.4. The further below 1 the relative risk, the stronger the protection. The correct answer is D. An RR of 0.4 means lower risk, not higher. Reading it as a 40% INC crease reverses the direction. Choice A wrong. The 0.84 is a ratio of risks, not the share of patients who had events, so it does not mean 40% had events. Choice B wrong. An RR of 0.4 is a 60% lower risk with a statin. What does this odds ratio indicate? A case control study of coffee intake in a disease reports an odds ratio of 1.0, with a 95% confidence interval of 0.8 to 1.3. Read the command meaning of an OR of 1.0. 1 is the null value, no association. An odds ratio of exactly 1.0 is the NULL value. The odds of exposure are the same in cases and controls, so there is no association between coffee and the disease. The confidence interval 0.8 to 1.3 also spans 1, confirming the result is not statistically significant. The correct answer is A. A strong positive association would require an OR well above 1, which is not the case here. Choice B wrong. A protective effect would require an OR below 1. An OR of exactly 1 shows neither risk nor protection. Choice C wrong. An odds ratio of 1 doing U means no association. Which measure of association do the cohort's incidence data directly support? An investigator runs a prospective cohort study, following exposed and unexposed groups over time, and measuring how many develop the disease. Read the command, the measure. A cohort directly supports. A cohort study follows groups forward and measures eye incidence directly, so you can calculate true risks in the exposed and unexposed and form their ratio, the relative risk. Being able to compute actual risk is the defining advantage of a cohort over a case control study. The correct answer is E. The odds ratio is the measure you are forced to use in a case control study. Where incidence is unavailable, a cohort can compute the true relative risk directly, so it is not limited to the OR choice A wrong. A prevalence ratio comes from a cross-sectional snapshot, not from the incidence a cohort measures. Choice D wrong. Cohort incidence data support the relative risk. What study design is this? Investigators use decades-old factory employment records to define workers exposed and unexposed to a chemical, then check who has developed cancer by today. Everyone is enrolled after the cancers have already occurred, but the groups are still defined by their past exposure. Read the command, name the design. Group by past exposure, outcomes already occurred, a historical cohort. This is a retrospective historical cohort. The key is that groups are defined by e-exposure, exposed versus unexposed workers, and then follow toward the outcome, exactly as in a cohort. It is retrospective only because the exposure and outcomes already occurred and are reconstructed from old records, not because of the exposure to outcome direction. The correct answer is C. A case control study would define groups by disease status, cancer versus no cancer, and look back at exposures, which is the opposite starting point, choice B wrong. A prospective cohort enrolls before the outcomes occur and follows forward in real time, whereas here the cancers have already happened, choice A wrong. Grouping by past exposure with outcomes already in is a retrospective cohort. What study design is this? To study a rare cancer, researchers enroll a group of patients who already have the cancer, and a comparison group who do not, then compare each group's past exposures. Read the command, name the design, start from disease status, look back at exposures. A CA case control study starts by selecting people B-wide disease status, cases who have it and controls who do not, and then looks backward to compare past exposures. It is the efficient choice for a rare disease because you begin with a ready group of cases instead of waiting for them to arise. The correct answer is B. A cohort study defines groups by exposure and follows them forward for the outcome, the reverse of starting with disease status choice. A. Wrong. A cross-sectional study measures exposure and disease at the same moment, without the case, versus control structure described choice D. Wrong. Selecting by disease and looking back at exposure is a case control study. What design is this, and what does it best measure? A survey measures both current smoking status and the current presence of chronic bronchitis in a population at a single point in time. Read the command, name the design, and what it measures. A one-time snapshot measures prevalence. Across, a sectional study captures exposure and outcome at a single point in time. A snapshot of the population. Because it counts existing cases rather than following people over time, it best measures prevalence. It cannot establish timing, so it cannot tell whether the exposure came before the disease. The correct answer is D. A cross-sectional study cannot measure eye incidence because incidence requires following a disease-free group over time to count new cases, choice E wrong. Measuring incidence would instead require a cohort design with longitudinal follow-up, not a one-time survey, choice A wrong. A single-time snapshot is cross-sectional and measures prevalence. Which design and feature best achieve this? Investigators want the strongest possible design to prove that a new drug actually causes improvement, minimizing both known and unknown confounders. Read the command, strongest design for causation. Randomization balances confounders you can't even see. A randomized to control trial provides the strongest evidence for causation because randomization distributes both known and unknown confounders evenly between the groups. That balance is something no observational design can guarantee, which is why the RCT sits at the top of the evidence hierarchy for a single study. The correct answer is A. Matching in the case control study controls only for the confounders you measure and match on, leaving unknown confounders uncontrolled, and it remains observational choice B wrong. An ecological study uses group-level data and is among the weakest designs for causation, vulnerable to the ecological fallacy, choice E wrong. A randomized controlled trial best establishes causation. Which of the following is essential for the consent to be valid? A surgeon is obtaining consent for an elective operation from a competent adult patient. Read the command. What makes consent valid? The patient must actually understand what they are agreeing to. Valid. Informed. Consent requires that a patient with capacity understands the procedure, its risks and benefits, and the alternatives, and agrees voluntarily. Understanding is the heart of it. A signature without comprehension is not true consent. Correct answer is E. A competent adult consents for himself, so a family member's co-signature is neither required nor a substitute for the patient's own understanding choice. A wrong. Consent is required regardless of how low the risk is, and low risk does not make consent automatic or unnecessary choice. B. Wrong. The essential element is that the patient understands the risks and alternatives. What is being confirmed? A patient with mild depression declines a recommended diagnostic test. Before honoring the refusal, the team confirms that he can understand the information, appreciate the consequences, reason about the options, and communicate a clear choice. Read the command. What the 4-part bedside check confirms. Understand, appreciate, reason, communicate. That is capacity. Decision. Making capacity is a clinical judgment made by a physician of whether a patient can understand the information, appreciate the consequences, reason through the choice, and communicate a decision. Depression alone does not remove capacity. What matters is whether he meets these 4 elements for this specific decision. The correct answer is B. Competency is a global legal status determined by a court, not the bedside clinical assessment described here. Choice A. Wrong. A power of attorney is a proxy the patient designates to decide for them, not the patient's own decision-making ability. Choice D. Wrong. This 4-part clinical assessment confirms decision-making capacity. What should the physician do? An adult patient's employer telephones the clinic and asks the physician to reveal the patient's diagnosis. The patient has given no authorization to share any information. Read the command. A right action about a third-party request. Confidentiality holds unless the patient authorizes disclosure. Patient confidentiality means health information cannot be shared with a third party, including an employer, without the patient's consent. Absent authorization or a specific legal exception, the physician must decline to disclose anything, even confirming or denying a diagnosis. The correct answer is D. Sharing the diagnosis with the employer breaches confidentiality and is not permitted without the patient's authorization. Choice A. Wrong. The employer's insistence does not override confidentiality, so confirming the diagnosis under pressure is still a breach. Choice C. Wrong. The physician should decline to share without the patient's consent. What should the physician do? A competent adult with bacterial pneumonia calmly and consistently declines antibiotics after clearly understanding that he may die without them, citing personal beliefs. Read the command. The right action when a capable adult refuses. Autonomy lets a competent patient refuse even life-saving care. A competent, fully informed adult may refuse any treatment, even one that is life-saving. The principle of autonomy. Because he understands the stakes and is consistent, his refusal of antibiotics must be respected. Disagreeing with the choice is not grounds to override a capable patient. The correct answer is C. Treating him against his clearly stated wishes violates his autonomy and constitutes battery, however well-intentioned choice, a wrong. Declaring him incapacitated has no basis. A well-reasoned refusal is not evidence of lost capacity, and disagreement alone cannot strip it. Choice E. Wrong. The physician must respect his informed refusal. That's the block. 40 reps on the numbers you must run cold on test day. 60 seconds to lock the formulas. Sensitivity and specificity read down the disease columns. Predictive values read across the test rows. Sensitive negative rules out. Specific positive rules in. Incidence counts new cases. Prevalence counts all existing cases and grows with duration. Use person time when follow-up varies. Odds ratio cross multiplies. Relative risk divides the two risks. Absolute measure subtract. The number needed to treat is 1 over the absolute risk reduction. Match the design to the question, and remember, a competent, informed adult can refuse anything. Train process, not memorization. StepLogic, learn how to think, not memorize. Next up, study design, bias, and inference.